Okay, madam, we are live.
Yeah. Good evening, everyone. So yesterday we spoke about the embryology of uterine artery and practical applications of the embryological knowledge in our surgical cases. So today, in continuation with something similar, Dr. Jay will talk about uterine vein, and we know that how venous bleed can be very troublesome, and it may be really frustrating thing during laparoscopic surgeries to control. So if we have a clarity on the anatomy, which again like depends on the embryological knowledge of ours, so it gives us more confidence in dealing with bleeding, if at all, if it happens. So over to you. And I think there will be some part where he will speak about retroperitoneum and the uterine vein, how it is actually important, maybe in radical hysterectomies too.
Yeah, so I'll start with the screen sharing. Okay, and I'll try to cover very quickly about embryology of the uterine vein, and I will try to also cover very quickly about anatomy of the uterine vein. Okay, so when we try to look at the anatomy, first I will just draw the uterus. Okay, this is the uterus. You have the ascending uterine and you have the descending uterine and you have the uterine artery. Correct? The uterine artery is actually originating from the internal iliac artery, anterior division. Okay, this is the uterine artery which we all know of. So we have discussed it in excellent detail yesterday. Everything about origin, anatomy, everything, embryology, everything. Okay, so when I discuss the uterine artery, hand in hand to the uterine artery goes the uterine vein. But if you understand, see, I am drawing the uterine vein very differently. Okay, and this is how the uterine vein is. The beauty about the uterine vein is that uterine vein is somebody who is going to go in straight line. Okay, we don't know why it goes in straight line. We have two uterine veins. One is the superficial uterine vein, which is also called as uterine vein, and then there is the beautiful deep uterine vein. All of them actually go and meet the internal iliac venous complex. Okay, so they all go and meet the internal iliac vein. Multiple variations are there inside that, and so we have studied this, no? If you ask somebody the branches of the internal iliac artery anterior division branches are so simple. You have obturator, you have uterine. We studied this yesterday, right? You have pudendal, you have middle rectal, and in some situations you have iliolumbar. So these are 4 or 5 branches which everybody will know. But the venous plexus is not like that. You know, the entire venous plexus, if we try to talk, no, there is similarity of only 70% in the venous plexus, especially in the pelvis. There are 30% variations in the venous plexus. Huh? So very few veins coming to the venous plexus are actually constant. You know what is constant is this, and that is the internal iliac vein. And you know how much long is the internal iliac vein? Around 1.5 to 2 centimeters. Bus. That is the only constant thing. Everything else comes and joins the internal iliac vein randomly. You know what is it called? It is called as confluence of veins. You know why is this word confluence used? The word confluence is used because embryologically, in the pelvis, if I just draw the pelvis something like this, the two walls of the pelvis, when the venous system is actually developing, the venous system is developing like this, like cavernous venous sinuses in the pelvis. Okay. Now, all these cavernous venous sinuses will again have differential canalization. One part will go here, one part will go there, one will go here, one will go here, one will go here, based on the amount of absorption. Because there are certain structures which will go from up to down, there are certain structures which will come from down to up. Understanding? For example, I'll just put a very simple example. One guy is called kidney. Okay. He goes from down, he starts originating down and then he goes up. Then there is another guy called ureter. It originates when the kidney is going up. So on its journey up, it is actually coming down. Then there is something called as uterus and fallopian tube. It actually originates somewhere here close to the aorta. Okay, on both the sides, and then it is coming down. So these people, this venous system is actually heavily confused. Where to send what? Okay, and when the embryological development is complete, that is approximately at 12 weeks of gestation. Okay, there is too much confluence of veins there. Because there is too much confluence of veins, some vein undergo regression, some veins stay as it is, and as a result of this, you find a beautiful 30% variation in the venous system. The only thing which stays constant, okay, which does not have any variation, very straightforward person like me, and that is this. He never changes. Ureter. It just stays where it is, in between the superficial vein and the deep uterine vein. Okay, this is constant. Yesterday we discussed uterine superficial, uterine artery will always go above the ureter because it is embryologically a separate component. Superficial uterine vein will follow the uterine artery, but deep uterine vein does not belong to the same embryology component as the uterus is. Okay. It is believed that the deep uterine vein actually comes from confluence of part of the cervix, part of the vagina, part of the bladder, which is in front, and and part of this. I will just draw this for all of you. This is the hypogastric plexus. Okay, that is why, remember this, that is why it is so important to understand that when you try to do nerve sparing surgeries, rather than understanding the hypogastric plexus, it is more important to understand the deep uterine vein, because deep uterine vein is something which you are going to see easily as compared to the hypogastric plexus, which you are not going to see very easily. Okay, just one more thing as a part of anatomy, which Shilpa madam may ask me little later, so I'll answer it right now only so that she does not get opportunity to ask that question. Okay, whenever you have a venous bleeding during hysterectomy, okay, see where that venous bleeding is going to be from. It is going to be somewhere here. See, here at the vault. Either you will have the venous bleeding at the vault, correct, or you will have a venous bleeding here at the level of the trunk. Okay, so if in case you are confused, array venous bleeding is there and the vein has retracted. Now what do I do? Okay, your answer is very straightforward. Whenever there is confusion, you have to go here. You have to go to the place where it meets the internal iliac vein and do something about it. Either you clip it, coagulate it, do whatever you want, but don't end up coagulating here. See, the distance between this and the ureter is very less. Don't end up coagulating here directly without retraction, because the distance between a unmobilized ureter and that free end of the vault vein or the vein at the vault is going to be very, very less. That is the reason for having maximum number of ureteric fistulas. Okay, unintentional coagulation at the vault. So please be careful, because now when you understand this anatomy, you will understand it very well. Having spoken this for around 5 to 7 minutes, I also want to tell you one very important thing. Remember, every vein in the human body carries deoxygenated blood. Because it carries deoxygenated blood, it really does not require any priority. Okay, even if there is some stasis of the blood which occurs in the vein, it is fine. As a result of this, the vein usually, no vein in the body usually has a very thick wall, because the pressure flowing through the vein is very, very less. As a result of this, most of these veins would undergo a collapse if you increase the pressure inside the pelvis by even more than 12 to 15 millimeters. That is the reason, that is the reason majority of the times when you are operating, you will see that some of these veins are actually very collapsed. Understanding, because of the effect of the pneumoperitoneum inside the abdomen, because these are small veins. Okay, even in pregnancy, God has not given vein priority. See how unfortunate it is for vein. Vein is like husband, no priority anywhere. You never look at uterine vein PI. You never look at uterine vein RI. You never look at apple bomb scoring based on uterine vein. Nothing happens to the vein. No, it is, you cut it, ignore it, nothing happens. Everything is based on artery, uterine artery PI, uterine artery RI, uterine artery this, uterine artery that. That is why vein feels very sad and it behaves like a husband, always standing, walking, and doing everything in a straight line. As a result of this, uterine artery is curvilinear, but uterine vein is very, very straightforward. Okay. Remember, if something happens to the uterine vein, let's assume the uterine vein breaks. Okay. Let's assume, I'll just draw something. Let's assume the whole uterine vein broke here. Okay. Nothing will happen. You have to just go and coagulate above, go and coagulate below, and the bleeding will stop. Because any which ways it is a low pressure system. So yesterday Shilpa madam had asked me a question that do you need to do bipolar and how much should be the surface area on bipolar while coagulating the artery. So we had mentioned a specific point that in the artery, because of that, pressure in which the blood is flowing, the coagulum gets dislodged. Nothing like that happens in the vein. Nothing gets dislodged. In fact, it will happily stay there, for 2 3 days. After that, the vein will realize, oh, I am obstructed. And then in that situation, when it is obstructed, it will automatically find its course. Because a venous obstruction doesn't really matter much. As a result of this, you have to understand one very, very important concept. Okay, part of the blood supply, okay, a small part of the blood supply, which is going to get compromised. And this is a very important clinical point. So, for people who are probably not listening for so long, can listen to this very nicely and importantly. Okay, just you have all seen this in your clinical practice, but you have never probably tried to figure it out. Okay, you have the infundibulopelvic vein and you have the uterine vein, correct? Now, whenever there is excessive blood supply which is coming, no, uterine vein is like, अरे यार वैसे भी मेरे को कोई importance नहीं, why should I work very hard? Some blood supply it will divert to the pudend, to the infundibulopelvic vein, gonadal vein. It will say, भाई थोड़ा सा बर्डन तुम भी उठाओ, थोड़ा सा हम उठाते हैं. As a result of this, when there is a high flow system, for example, arteriovenous malformations, uterine cancer, sarcoma, very large fibroids. In all these situations, you will find that the gonadal vein is dilated, correct? And this gonadal vein dilatation is an indication that there is too much pumping in of blood supply happening inside the uterine anatomy, which is causing the gonadal vein to be dilated. Even in pregnancy, if you see, the gonadal vein is going to be grossly dilated because uterine vein alone does not want to take the burden of so much blood flow. Having said this, having understood this, probably these were points which we all knew. I just thought I will revise. I will play a very short video of a surgery which we performed today. And if you see, this is exactly how you are supposed to. This is a live video. So this is exactly how much time it will take. Hold the IP ligament, pull the IP ligament cranially. If you pull the IP ligament cranially, the first structure which you see is obviously on the lateral pelvic wall, that is the external iliac vein, and there comes our ureter. See, ureter is always, ureter is more like Instagram. It always wants to be in the limelight. The minute you open the retroperitoneum, ureter wants to show itself. I am here, I am here, I am here, I am here, like that. So ureter is not at all something you should be worried about. See, the minute you open the retroperitoneum, left side mein, I mean one lateral pelvic wall, you will have the external iliac, medial side you will have the ureter. Okay, then you have to go to little depth. That means you have to go to little bit Facebook. Then you will find the internal iliac artery. That internal iliac artery will be, hidden somewhere due to security reasons. It will be lying down somewhere. You have to dissect a little, and then ultimately, see, everybody wants limelight, so even it will show itself. And he will say, okay, okay, I am the internal iliac artery. You can see that beautiful obturator artery going there. See, that is obturator artery. Right? So cute it is, no? And then you have the anterior division. Anterior division is branching nicely. It wants to show that, okay, I'm anterior division of internal iliac. I have branched. That's the uterine vein underneath. I'm going to open it and show it to you. Open means dissect, not cut. Okay. And here you have, see this beautiful uterine artery. Right? Such a nice artery it is. But see, this time God has given two specimens there. One is the uterine artery, and underneath that you will find a vaginal artery. So there is a little variation in this case. I told you yesterday also. Some cases you will have vaginal artery. See here, one part, upper part is getting into uterine artery. See that, I went very close. Upper part is uterine artery, lower part is vaginal artery. And underneath that, that little ignorant structure whom you just did not see it at all. Okay, so if I just show that structure, if my cursor is coming here, see that. That is the uterine vein. Okay, see, my itch is such, that when I see these arteries, I actually want to go and coagulate them. But then I did not. Okay, so there exposes itself the uterine vein. Once the uterine vein is exposed, if you go little deep in that plane, you will start seeing the deep uterine vein. Very simple it is. See, uterine vein is so small, so thin. I am holding it. I am little trying to play with it, but I am not going to cut it. But I am decided to go one plane below. Now, when I go that little one plane below, you will find the deep uterine vein. See, you have to dissect. Little, you have to keep on dissecting. There it will come. Halka hat. Okay. So I'll just fast forward because all this is not at all required. Yeah, this is important. See how it is. That uterine artery and uterine vein will always cross the ureter. See, that is where they are going to cross the ureter. So you keep on dissecting them a little, you go little down. And when you go little down, all this fascia, no, all this fascia is unimportant. See, there it is hidden. That is uterine vein, deep uterine vein. Why it is called deep uterine vein? Because you have to go to the depth to find it. See that? There it exposes itself, deep uterine vein. But you should never be satisfied at such a minimal exposure. Okay, I will go and I will always expose it a little more and I will be like, nahi, agar dekhna hi hai, so you have to see the whole uterine vein. That is the importance. Can you see the plexus there? You can't see any plexus there, but the plexus is somewhere there. So underneath the deep uterine vein is going to be the plexus. Okay, so that is your deep uterine vein. Let us just expose it little more. You'll see it. It's actually very nice. That is the deep uterine vein. That is the superficial uterine vein, superficial uterine artery, or I mean simply the uterine artery going there. And you can see a terminal part of the deep uterine vein actually. I'll just show it to you. So when I just cut this region, yeah, the entire uterine vein will get exposed. See, simple dissection, no rocket science. Actually, do we end up dissecting the deep uterine vein like this in all the cases? The answer is no. We end up dissecting. See, now you can see, Shilpa madam, you can see.
Yeah.
Beautiful it is, no?
Mm.
Full uterine vein. See, full uterine vein can be nicely exposed. Yeah, you can understand the entire anatomy of the uterine vein. You will see that uterine vein and ureter and everything is now so nicely seen. But just keep this much in mind and keep one more important thing in your mind, that it is not at all a compulsion for anyone to dissect the deep uterine vein in any situation. Okay, it is not a compulsion. But you have to know the anatomy of the deep uterine vein and the superficial uterine vein, because this is very, very important in advanced cases. Otherwise, uterine vein is such a good structure that you can simply go and coagulate it wherever you want to go and coagulate it. No problem will happen. Make sure of one more very important thing. If there is an inadvertent bleeding through the uterine vein or through the venous complex, please go to the confluence, coagulate the confluence. It's very easy to coagulate the confluence. In fact, to be very honest with you, if you can't coagulate, if you don't have a clip, go there and apply pressure with a gauze piece for approximately 7 to 10 minutes. If you apply that pressure, your pressure itself will create a platelet coagulum there, and that platelet coagulum will itself play a very important role in stopping the bleeding from there. Okay, so with that, I complete and I'll answer some questions by Shilpa madam.
See, I mean, this may not be relevant in laparoscopy, but when there is placenta previa and all, right? I mean, see, this uterine vein. What is your thought on suturing these veins when they open up like lakes? I mean,
So the word which you used is correct. Then they are not lakes. Then they are not veins. They are lakes because they are confluences of many veins joining together and forming a placental lake. Understanding? See, remember, even if you suture them, these are placental lakes. They have only one wall. They have only the lower wall. They don't have the superficial wall. So it is very difficult to control bleeding from them. Okay, very, very difficult to control the bleeding. And you will not be in a position in that type of a situation to go and suture each and every vein which is supplying that. Okay. As a result of this, you have to be very, very careful, as you mentioned, when you have placenta percreta. That is only going to happen mainly in placenta percreta. If it is placenta accreta, then it is very straightforward. Go and ligate the internal iliac and excise that part of the accreta and suture and reconstruct the uterus. But in percreta, you don't know which vein has dilated and which vein is supplying. Okay. In percreta, in that situation, the best option you have, as has been discussed on multiple platforms, is to use a common iliac clamp that reduces the pressure of even these veins, and it will give you some benefit in ligating them.
okay, see, for arterial bleeding, we have the easier route to ligate the internal iliac artery. What happens to these venous bleed? Like, I mean, if we are finding it challenging to control it, like pressure, even many a times, I mean, we keep coagulating without actually dissecting the ureter properly, and then we end up in trouble. So, what is your tips on, like, managing this venous bleeding, especially if we are a little lateral?
No, every bleeder for every vessel, the principle is the same. Isolate, skeletonize, and coagulate or clip, right? So the word isolate is important. Simultaneously, word skeletonize is important. If in case you want to coagulate, that is the third step. You have to isolate and skeletonize. You can't really go and coagulate like a bunch, because here is one situation where the ureter is very close and your thermal injury will cause a late sloughing of that ureter, which will end up as a fistula.
So, between the arterial bleed and venous bleed, which do you think is easier to tackle in laparoscopy?
Both.
No.
No, both are easy to tackle, madam.
So, how the principles are different in each of them? I mean, is it very different with the amount of energy you use?
No, it is the same. Again, if you follow the principle of vascular dissection, that is isolate and skeletonize, then as I told you, you just need, it's a less than 5 millimeter vessel, madam. So it will any which ways come in the grip of your bipolar, and you will be in a single burst, you will be able to coagulate it off.
So most of the times we actually don't want to look at this deep uterine vein because we are doing only benign cases of hysterectomy and we don't need to actually do those. So in which situations do you think like we need to have this deep uterine vein? I mean, is it in radical hysterectomies? Is it in
Radical hysterectomy and endometriosis. In endometriosis, you will require to go to the deep uterine vein in almost every case, because you have to cut the uterosacrals in most of the cases. And just below the uterosacrals, you have the deep uterine vein. So you will have to end up dissecting the deep uterine vein, madam.
So in chronic pelvic congestion, okay. So this venous plexus and these venous stasis which happens, okay. So how do you think, like, I mean, uterine vein, like which of it, the superficial or deep, among these, like, is there a standard that the superficial vein is important than the deep uterine vein, or which is the bigger one? What is the drainage of each one of them?
See, madam, the deep uterine vein is the one which predominantly carries the stuff from the cervix. So when you are trying to speak of chronic PID, it can also involve chronic cervicitis. Okay, along with that. And when it causes that, we have tried it so many times, right? We end up doing parametrectomy. So what we do, we cut the uterine artery, cut the uterine vein, and cut the deep uterine vein. Okay, so automatically the flow only goes down. Then the flow is only dependent on collaterals coming in from the ovaries, and we have seen patients getting a wonderful benefit, out of that. So one can attempt to do that, but it's not a, see, people will not want to attempt that because it is too radical an approach for chronic pelvic pain, or too radical an approach for chronic cervicitis, which is why it is to be reserved for cases where everything has failed, you know. And if in case you do that, patients have fantastic outcomes out of that.
Yeah, but yeah, I think we are good. I mean, but what does the uterine vein? I mean, what else is? Oh, there's one more question. Wait, I will just check out. Ovarian venous plexus gets pricked during LSES. How do you manage?
Coagulate it.
Yeah, that's all.
Yeah, just coagulate it.
So, do you do this tying or like the clips more than the coagulation for these?
No, I just coagulate with the sharer, madam.
Mhm. Yeah, I think we are good. I mean, it was really good. So, in Mullerian anomalies, like we see that each case is so unique and each case is so different.
Yeah.
So, the venous system, as it is, like there is so much variation already. As you said, like there is 30% variation in the venous the system. So, in Mullerian, do you expect like when there is a rudimentary horn, when there is a bicornuate or a diadelphys and all that? I mean, will there be a lot of variation in the venous anatomy?
Uterine anatomy, superficial uterine vein will vary. Deep uterine vein will not, because deep uterine vein's embryological origin is different from superficial uterine vein. So
Mhm.
deep uterine vein is going to be there only,
Yeah.
same place, underneath the ureter.
Mhm. Okay. Yeah. Thank you so much. I think it was good. It was fine. Thank you. Good night, everybody.